Hello everyone. Today we will take our first pharmacology lecture in the course. The title of this lecture is Medications that are used for antidepressants. And these medications are used to treat a medical condition called depression, or in Arabic it is al-iktiab. Now, what is the definition of depression? Depression is a sad blue mood that goes above and beyond normal sadness or grief. So important thing here is that it goes beyond the normal sadness. So it is normal sometimes for individuals to feel sad or being depressed for a short period of time. And that's usually happening after an incident of losing a relative, a friend, or having a family problem in life, or for example, failing in the exams or at school. So all these are examples of conditions that usually there is a short period of depression. Now, to go deep into this, we know that the grief or losing somebody close to you is followed by 5 stages of grief. And these 5 stages, I want you to look them up. Usually, one of them, it is the fourth stage where the patient goes into depression. Now, this is normal after grief or during grief or after a problem. But if it's extended for too long after that period, so in that case, we think about that patient has depression. But I want you to go and see what are the 5 stages of grief. Now, what are the signs and symptoms of depression? Although it is a central nervous system disease, we have both psychological signs and symptoms as well as physiological signs and symptoms. The psychological symptoms include low mood, loss of interest from the patient, reduced energy for doing normal behaviors, for example, participating in activities, socializing, going to work with enthusiasm. Usually, patients with depression they do not have that energy. Uh, Most of the time, they have feel of guilt, that as if they are doing something guilt, and they want to avoid meeting with other people, as well as feeling worthlessness. But as I said, we have some physiological signs and symptoms. This may include sleep disturbances, and the sleep disturbances are usually either increase in sleeping time during the day or decrease in the sleeping time during the day. So there is no specific outcome or sleep design for each patient, for all patients. Each patient has his own signs and symptoms in sleep disturbances. Decrease in appetite, they decrease kind of the amount they eat and the appetite, as well as loss of libido, which is the loss of interest of having sex. Now, one major sign and symptoms that may appear in some people with depression are people who may commit or thinking about suicide. And this is one of the major problems for or like serious outcomes for people with depression, and that's why early diagnosis as well as seeking treatment is very important in patients with severe depression. Also, depression may lead to psychosis, and we will have a lecture about antipsychotics in the near future. What are the types of depression? We have depression that comes after a predisposing factor, and that's called secondary depression. As we said, if it's for a short period, we cannot diagnose the patient with depression as a disease. Maybe the patient is depressed during that short period, but it's not does not have a depression, and usually it's not a condition where we want to seek treatment for. So this is a secondary depression. We have also a major depressive disorder. A major depressive disorder is that there is no predisposing factor and it is very severe. Some research indicate that it may be hereditary, and you can see some families that the mother and the father, they have depression when they have in the past, and then their offsprings also suffer from depression with no predisposing factor. Or sometimes it can be called endogenous. It's not exogenous due to, for example, uh, uh, factors or due to problems in the life of the patient. So it's endogenous, so there is no predisposing factor. And we have one special type of depression, which is bipolar. Bipolar or ثنائي القطب. This is very common, I think, even in Jordan as well as the United States. And from its name, bipolar, where the patient has both depression as well as mania, which is the opposite of depression. So he has decrease in mood, which is depression, as well as elevated mood. And usually this swinging between in the mood usually happens in like for months or in a short period. So some patients may suffer for 2 months of depression, and then a week after they start to have mania and they go back to depression. Some people may have it like in short period. Maybe today I'm depressed, tomorrow they have mania, and then they spend another 2 days of depression. So this is bipolar disorder. We will come into this bipolar at the end of the lecture. Now, physiologically, what is the pathophysiology for depression? And if we know the pathophysiology, so then we can determine the treatments needed for these patients. The most acceptable theory for depression is that there is a decrease in neurotransmitters in the brain, including the serotonin or 5-HT, as well as norepinephrine. So a decrease in these neurotransmitters may lead to depression. Again, this is a theory, and that's why most of the medications that we will study today are drugs that potentiate or increase the levels of these neurotransmitters in the brain. Now, this is theory. That means some observation can support that theory and some other observations may be against this theory. What are these observations that are with this theory? For example, reserpine depletes serotonin and catecholamines. So reserpine is a drug that was used extensively in the past. Now it's used very little in patients with hypertension. It's a drug that goes into the vesicles that package the neurotransmitter dopamine into the vesicles. So it goes there and inhibit the dopamine packaging into the vesicle. That means the vesicles will not contain dopamine and norepinephrine, and that will lead to decrease in norepinephrine in the vesicles and eventually in the synapse. They found that reserpine is a drug can produce depressive-like symptoms and signs in patients who take them. So from that, they think that that's why norepinephrine is an important key player in the in production of depression. They also noticed that patients with depression has decreased level of MOPIG in urine. So MOPIG, it's a short abbreviation for a longer chemical structure. You can look it over. It is a metabolite of norepinephrine. So because they have decrease in norepinephrine in the brain, that means they have decreased metabolism. That means there is a decrease in this metabolite. So from that, they said, okay, maybe those patients do not have enough norepinephrine in their brain. Also, some also depressed patients, they found to have a decreased levels of the serotonin metabolite, which is the 5-HIAA, and again, you can look into this the abbreviation over the internet or in the book. They found that there is a decrease in this metabolite in the brain, and they consider that that's why there is a decrease in serotonin. Finally, the medications that we will talk about, and the most ones that are approved in treating depression are medications that increase the concentration of both norepinephrine as well as serotonin. Here, I put just the examples of these medications. We will study them, the monoamine oxidase inhibitors, as well as the SSRI, SNRI. All of these medications increase the norepinephrine and serotonin in the system. Now, let's talk about the observations that are against the theory of serotonin and norepinephrine. Now, first of all, the drugs that are used as antidepressants, they produce immediate increase in norepinephrine and serotonin levels in the synapse in the central nervous system. However, these patients usually will feel the effect of antidepressant after usually a period of time that lasts maybe weeks or months. So this is against the theory of serotonin and norepinephrine. Also, there are some drugs that do not actually increase norepinephrine and serotonin, and we will study some of them. But still, they are considered as antidepressants. And finally, we have some medications that increase the levels of serotonin or norepinephrine in the synapse, but they are not effective as antidepressants. And the biggest two examples are two drugs of abuse that are cocaine and amphetamine. Now, what are the classification of antidepressants? Here are the major classes that we will talk about. We have drugs that are considered monoamine oxidase inhibitors. We have tricyclic antidepressants. We have second generation antidepressants, and the two subtypes, important subtypes that you need to know are the SSRI and SNRI, selective serotonin reuptake inhibitors, and selective serotonin norepinephrine reuptake inhibitors. As well as in the last group, we will talk about two medications that are considered atypical antidepressants. Before we move to the first class, let's talk about the general principles of antidepressant therapy. As I mentioned earlier, the effect is usually delayed after the administration of the drug. Now, nobody exactly knows the reason, but for the beneficial and medical effect of these drugs, we ask the patient to wait for a specific, like a long period of time, usually 2 months at least, to start feeling the effect of, or the therapeutic effect of these medications. Although we have multiple classes, there is no evidence medically that one class is more efficacious than the other. However, the main differences between these medications are some of them have serious side effects and some other medications have less side effects. But as a therapeutic outcomes, there is no specification or no differences between their efficacy. And usually it's different from patient to patient, where they can feel the therapeutic effect, which medication can produce the best therapeutic effect for each drug. Now, in case the patient does not respond to the first medication, so then we can think about changing the medication into other medication. And in case the medication does not is not efficacious, so then we think about a combination of two medications. Now, a major side effect of all antidepressants, even if I will not mention them, is that it's going to be the opposite of their indication. So although they may produce, they are used for depression, so thus the main side effect for all of them is mania. Although this sounds like it's not a bad side effect, however, mania is always associated with suicidal attempts and suicidal thoughts, and we should consider that once we start the initiation of the therapy. Now, let's talk briefly about the life cycle of serotonin. So serotonin, or its other name 5-HT, is synthesized from the for the amino acid tryptophan, and that's through two steps process, including two enzymes to synthesize serotonin. And serotonin can be metabolized by the enzyme monoamine oxidase, MAO, and that's what we will talk about soon, to the metabolite 5-HIAA, the one that I also mentioned earlier. So it is synthesized from tryptophan and metabolized by MAO to 5-HIAA. Now, as all other neurotransmitters, the serotonin is synthesized and packaged in the presynaptic neuron, and once the action potential arrives, the vesicle binds to the membrane and releases the neurotransmitter into the synapse, where it binds to the postsynaptic receptors. Now, serotonin has multiple types and subtypes of receptors postsynaptically, and these ones are you don't need to know specifically each one of them, but at least we have 16 subtypes of serotonin receptors. Now, the effect of serotonin is dissipated or decreased by the reuptake through the presynaptic transporter, or what we call SERT. So it's serotonin transporter. It's taken presynaptically back to the presynaptic neuron, where it's packaged again for further use in the future, and this will decrease the levels of serotonin in the postsynaptic receptor. Also, I want you to notice here that also we have a presynaptic receptors right here, specifically of the subtype of 1A. The function of these receptors as well, so these are receptors, not transporters, so they are different than serotonin transporters. So the function of this receptor is that providing a feedback inhibition. Once the serotonin is too much in the synapse, it binds in these presynaptic receptors and will inhibit further release of serotonin from the presynaptic neuron. This graph shows the life cycle of norepinephrine, the other important neurotransmitter related to depression. Norepinephrine, as you should know by now, it is first amino acid is tyrosine that is metabolized to L-DOPA and then dopamine. Dopamine is packaged into the vesicles, and inside the vesicles we have enzymes that convert dopamine into norepinephrine. And once again, upon activation of the presynaptic neuron, the norepinephrine is released into the synapse, where it binds to the postsynaptic receptors, and its action is aborted by either the reuptake into the presynaptic neuron by this channel or this transporter, which is called NET, so norepinephrine transporter, or it can be diffused in the area around that eventually reach the liver, or in the presynaptic neuron we have enzymes such as the monoamine oxidase enzymes. So these enzymes metabolize norepinephrine to their metabolites, and we already know one of them, which is the MOPEG enzyme, MOPEG metabolite. So now let's go to the first class of antidepressants, which are the monoamine oxidase inhibitors. Now, the sequence or the arrangement of the classes, it's not because of their effectiveness in treating depression, neither they're the most commonly used ones. Actually, monoamine oxidase inhibitors are the first class to be introduced in the clinic to treat depression. Now, monoamine oxidase enzyme itself, we have two types. We have monoamine oxidase A and monoamine oxidase B. Monoamine oxidase A is not selective to specific neurotransmitter, thus it metabolizes all the neurotransmitters, serotonin, norepinephrine, as well as dopamine, and thus it's very good into depression. The monoamine oxidase B, on the other hand, is selective for dopamine, so it only produces metabolites of dopamine, and it has no effect on norepinephrine or serotonin. It is very important in Parkinson's disease. However, please remember that previously when I mentioned that some medications that does not have does not produce any increase in norepinephrine or serotonin may have antidepressant effect. And now we will study an example of such medication where it's selective for monoamine oxidase B and can be used as antidepressants. Thus, these enzymes, the monoamine oxidase inhibitors, bind to the monoamine oxidase enzyme and they inhibit it irreversibly. We have two types. We have non-selective monoamine oxidase inhibitors and selective monoamine oxidase inhibitors. Non-selective means they inhibit both type A and type B. Selective, that means they inhibit either type A or we have other medications that inhibit only type B. Examples of non-selective: phenelzine, tranylcypromine, and carboxazide. In the selective part, we have the monoamine oxidase A selective inhibitor, maclopamide, and for specific for monoamine oxidase B, we have selegiline. Now again, selegiline, we will come back to it when we talk about Parkinson's disease, but also selegiline can produce antidepressant effect, although it's selective for monoamine oxidase B, which is selective for dopamine metabolism. Now, an important thing about monoamine oxidase inhibitors are the side effects. There are two major side effects for amine oxidase inhibitors, and you need to know them. Monoamine oxidase inhibitors, the first side effect is the risk of production hypertensive crisis. And this hypertensive crisis is usually happening if patients took monoamine oxidase inhibitors with tyramine containing food. So some specific types of food are containing a lot of tyramine. It's a chemical present in cheese, chicken liver, red wine, fermented meat, and this may produce what we call the hypertensive crisis. And because cheese has a lot of tyramine, so they also call the effect the cheese effect. So people who ingest a lot of tyramine containing food such as cheese and they are on monoamine oxidase inhibitors, they have at high risk to the production of hypertensive crisis. From its name, hypertensive crisis, it means a lot of a huge increase in blood pressure. We have another type of food that contains it, and I know a case where it is very sensitive to tyramine that are in avocado, the fruit avocado. It has a lot of tyramine, and I know a case where the patient ingested a lot of avocado and it produced hypertensive crisis. Tyramine itself is a catecholamine releaser. So what does that mean? So this figure taken from the Nature Reviews journal. In the right side of the figure right here, we have the tyrosine, where it is converted to dopamine and then norepinephrine and or noradrenaline, and there it can be packaged and be released to the synapse. That's normal, what's going on in our body. If we take monoamine oxidase inhibitors, that means we decrease the metabolism of norepinephrine, and that all of the norepinephrine should go to the vesicles, and then they will be released into the synapse, and this will increase the norepinephrine itself, and that's the mechanism of action of monoamine oxidase inhibitors. Now, tyramine on the other hand, we have tyramine in the guts, we have tyramine in the intestine. We have the monoamine oxidase in the gut and intestine. So if you eat a lot of tyramine, usually it is ingested in the liver as well as in the intestine. But if you are taking monoamine oxidase inhibitors, they will inhibit the enzymes in the central nervous system as well as in the periphery, and thus liver enzymes as well as small intestine enzymes, they will inhibit it, and thus tyramine will not be metabolized in the liver or in the small intestine, and thus we have a lot of tyramine that can go into the bloodstream and be available into the to the blood-brain barrier to take it. So then once it reaches the neurons, the tyramine will be administered into the neurons, and actually in this case it competes with the norepinephrine into being going into the vesicles. So it goes there, and it's by itself, it goes there and it releases or enhances the release of these vesicles to go and empty its contents, which is the norepinephrine, into the synapse. So thus we have norepinephrine that will be packaged at higher concentration because monoamine oxidase is inhibited, as well as we have a lot of tyramine that goes here and also enhance the fusion of the vesicles into the presynaptic membrane, and that will produce even further release of norepinephrine. And thus we have a lot of norepinephrine in the system, and norepinephrine, we know, is the main neurotransmitter in the sympathetic nervous system, and you should know by now the effects and side effects of the activation of sympathetic nervous system that will lead to a huge hypertensive crisis and increase in blood pressure. That is an emergency case, and we should take the patient directly into the emergency room. Now, what do you think the treatment in such case? The patient has a huge hypertensive crisis. The patient may suffer from bradycardia as a reflex bradycardia, but it has a huge hypertension. So in that case, we have to decrease the hypertension very quickly. Of course, we have to stop the medications. We have to stop the monoamine oxidase inhibitor. We have to stop the tyramine if the patient is taking tyramine. If we can do a gastric lavage to eliminate any further tyramine in the gut or in the stomach. But more importantly, we have to manage the hypertensive crisis. We have to give a medication that decreases hypertensive crisis, and in such case, we can give medications that block the alpha-1 receptors. Alpha-1 receptors in the small vessels produce vasoconstriction, and that will produce hypertension. If we give a blocker, so that means we produce dilatation. So we can give two medications that block the alpha-1 receptors. These medications are prazosin as an example, as well as phentolamine, which are alpha-1 blockers. Now, the other major side effect for monoamine oxidase inhibitors are the what's called serotonin syndrome, and this is also happening once we take these medications with other medications that produce that increase serotonin in the central nervous system. Now we will study later in this lecture some of these medications that increase the serotonin in the such as SSRI in the central nervous system. But also remember that could be also possible in any drug that increases serotonin in the synapse in the central nervous system. So what is serotonin syndrome? Serotonin syndrome, this is a brief on the serotonin syndrome signs, where we have cognitive, autonomic, as well as neuromuscular effects. The patient may suffer from confusion, hyperactivity, hypomania, hyperthermia, hypertension, clonus, hyperreflexia. So all of this may produce serotonin. These are the signs and symptoms of serotonin syndrome. Usually the diagnosis is hard to know alone from these symptoms. So usually taking the patient's history, usually from the accompanying person with the patient in the hospital, taking a good history will give you an idea that this is serotonin syndrome. So in such case, we have to also to manage the patient quickly. So serotonin syndrome, we have to give cyproheptadine. Cyproheptadine is a first generation antihistamine, as well as the drug itself. Cyproheptadine is anti-serotonergic anti-serotonergic receptor, which means it's antagonist at serotonin receptors, and thus we can manage the patient by giving this medication. Now let's move to the second class of antidepressants, which are the tricyclic antidepressants. And as you can see from the chemical structure, they are tricyclic. They have 3 cycles, and they are different in their group right here. And these medications also are old medications. And right now, although they are still in the market, but their use is for other indications, as we'll see in the next following slides. So their mechanism of action is just inhibiting the serotonin as well as the norepinephrine uptake from the presynaptic neuron. You remember when we talked about the SERT and NET transporters? So they inhibit that transporter, and thus we increase norepinephrine and serotonin in the synapse. So this is briefly the mechanism of action. They work right here, where they block the reuptake of both serotonin and norepinephrine. Now, it's good and bad thing that they also target other receptors. So they can block other targets such as alpha blockers. They can block adrenergic receptors, alpha adrenergic receptors. They can block muscarinic receptors, as well as they can block histamine receptors. You may use these off-target effects other than depression in treating other diseases, as we'll see in the near future, as well as they also a side effects for these medications. So if you give a depressant patient these medications, so you have to tell them that you may suffer from these side effects related to the anticholinergic, antiadrenergic, and antihistamine action. Examples of medications that are tricyclic antidepressants, we have imipramine, desipramine, amitriptyline, as well as nortriptyline. Now, the effect of tricyclic antidepressants, as I mentioned, it can be used for other indications. Now, if normal individual took the tricyclic antidepressants, nothing will change in him, and only the patient will suffer from their side effects. As if like a normal individual, is he like to increase his mood? No, the tricyclic will not help the patient to improve in his mood. Now, a specific drug in this group, which is imipramine, is helpful to treat enuresis, which is involuntary urination, especially in kids like 5 years old, 6-year-old children who are still does not control their enuresis, and they may have bedwetting each night. So they use this drug imipramine to treat these patients. And the mechanism of action you should know now, because they have cholinergic, anticholinergic activity. So it will stop the urination by anti-muscarinic effect, which is one of the outcomes of blocking these receptors. And the second mechanism for the imipramine to use or to treat enuresis is by blocking the REM sleep. We have different kinds of sleep, or like cycles in the sleep. We have REM and non-REM. And they found that like too much REM sleep will produce this kind of enuresis. So this imipramine will affect the sleep cycles and will decrease the REM sleep. REM comes from rapid eye movement, so it will decrease the rapid eye movement, and that will help the patient to manage or to control the involuntary enuresis. We have another drug that also used other than depression, which is it's amitriptyline. It's used in migraine and neuropathic pain. The pharmacokinetics of all tricyclic antidepressants, they are well absorbed orally, as well as they are metabolized in the liver. Regarding the side effects, please think about their effect on their muscarinic, adrenergic, as well as histamine receptors. So you should think about anti-muscarinic activity, what's their effect on vision, saliva, and urine, and you should know by now what is the effect of anticholinergic drugs. Alpha antagonist in the blood pressure, it will decrease blood pressure and eventually that may affect the heart rate and produce tachycardia, reflex tachycardia. Antihistamine activity, it will produce sedation as well as weight gain. It may also affect the cardiac function and may produce cardiac arrhythmias. Now let's move to the SSRI, which is it is considered as the first-line therapy in treating depression. And please remember that when we say first-line therapy or first-line treatment, it's not because it's the more efficacious, but it has the least side effects compared to the others. And that's why they prefer to use SSRI for selective serotonin reuptake inhibitors. The good thing about them, their diminished side effects due to their no muscarinic as well as no adrenergic and no histamine activity. These drugs can be also used in other conditions such as OCD, obsessive compulsive disorder, PTSD, panic disorders, as well as generalized anxiety disorders. They are well absorbed orally and they are also metabolized in the liver. Some drugs can be metabolized into active metabolites and that may extend their half-life. So some of them have short half-life, some of them have long half-life, such as fluoxetine, which is the longest half-life among SSRIs. Fluoxetine as well may inhibit the liver enzymes. They are excreted through the kidneys. Drugs you need to know is maybe the prototype is citalopram, which is Celexa. Maybe it's not very common in Jordan, but it's in other countries it is very common. Fluoxetine or Prozac, it is very common in Jordan and it's very preferred in children. Fluoxetine, and it has a long duration of action. In Jordan also we have escitalopram as well as sertraline, and these drugs are preferred in adults. Side effects, sleep disturbances. The patient already has sleep disturbances, but during the transitional period, it also needs some time for sleep to be managed correctly. Sexual dysfunction is a important side effects, and the patient should be aware of this side effect, especially if they are married. Suicidal thoughts, and I put here suicidal thoughts under black box because it's not only SSRI, but all antidepressants are black box for their suicidal thoughts and suicidal attempts. And one important effect is hyponatremia, and this is very prominent in elderly, and this is a serious side effect in SSRI specifically, hyponatremia. Now, if a patient stopped using SSRI, they may suffer from discontinuation syndrome. This may include headache, malaise, nervousness, and as well as sleep disturbances. The discontinuation syndrome is more common in patients who took the short-acting drugs, and it's less prominent in long-acting medications such as fluoxetine. So fluoxetine is the safest in production of discontinuation syndrome. Let's move to the next class, which is a mix of serotonin and norepinephrine reuptake inhibitors. And the drugs you need to know, we have duloxetine, venlafaxine, and desvenlafaxine. Regarding their mechanism of action, from their names, serotonin norepinephrine reuptake inhibitors, so they inhibit the serotonin and norepinephrine, just similar to tricyclic antidepressants, the mechanism of action, but these drugs differ from the tricyclic by their chemical structure, so they do not have the 3 cycles, as well as they do not have off-target effects, so they do not affect the muscarinic or adrenergic or the histamine receptors. They can also be used in other uses, such as in neuropathic pain is another group of drugs that can be used other than depression. For side effects, they affect both serotonin and norepinephrine. So they produce similar side effects to the SSRI, as well as since norepinephrine now is increased in the system, that also may produce increase in blood pressure, sweating, and urinary retention. Now let's move to the last class of drugs that use in depression, which are atypical antidepressants. We have two main medications as atypical antidepressants. The first one is bupropion. In Jordan, bupropion is prescribed in King Hussein Cancer Center in Amman, which is specified for cancer patients. And because cancer patients, especially at their long-term treatment or in their end-of-life time, usually they have severe depression, and they already have, of course, pain. They have side effects from the chemotherapy they are taking during the treatment of cancer. So they have a severe depression, and part of that management is by giving a strong antidepressants. And bupropion is one of these strong medications used as antidepressants. Its mechanism of action, it blocks both NET and DAT, or the dopamine transporter. And it can be used in other conditions. One main advantage of bupropion that it's used in patients who are seeking smoking cessation. Smokers who want to stop smoking tobacco, bupropion is one of the drugs that can be given for these patients. And the side effects, since it affects both dopamine and norepinephrine, the side effects are related to the sympathomimetic activity. Now, the second atypical antidepressant is a drug called trazodone. And trazodone is a drug that have a mixed action, so it binds to some receptor subtypes and produce antagonists of serotonin receptors, and it binds to other subtypes of serotonin and produce agonist. So it has both agonist and antagonist on the serotonin receptors, depending on the receptor subtype. And now I want you to remember the action of presynaptic serotonergic receptors. When I told you when serotonin is too much in the synapse, it binds to the presynaptic receptors and activates the presynaptic serotonergic receptors, especially at the 1A subtype, and produce inhibition of further serotonin release. So if we block this receptor, we produce increase in serotonin release. So it can be agonist and antagonist depending on the receptor, as well as it is a SERT inhibitor. It has no anticholinergic activity as well. Now, we just finished the 4 main classes or 5 classes for treating depression. However, there are probably another approaches to treat depression other than pharmacology, so non-pharmacological approaches, and sometimes these approaches are more effective than pharmacology, or at least they should be in combination with medication. We have something called CBT, or cognitive behavioral therapy. This is very widely used for psychiatrists or psychotherapists to help the patient to record his daily life events and his feelings, and they go through that with the patient, and it can help the patient to realize things that makes him worse or better. Naturopathic therapy, which is from its natural, so they can use plants that is probably not approved as a medication, but the nature or the plants from the nature that can helpful. Biological interventions, physical activity, psychotherapy, all of this can help in treating patients of depression. Okay, now let's move to the next or the special type of depression, which is bipolar. And it's not depression itself, it's not depression alone, but it's a mixed disorder that involves both depression most of the time and mania from time to time. Mania is the opposite of depression. So in the case of mania, the patient will have a little sleep, he may talk rapidly, inconsistently, non-stop, and has a lot of energy, although last week or after a time the patient will have little energy, and that's why it's bipolar. It has both depression as well as mania. Having mania alone without depression is extremely rare. Now, bipolar, as I mentioned, there are different types of bipolar, but I think they, in general, they classify to part 1 and part 2, or type 1 or type 2, and you will take more about bipolar probably when you take psychiatry in the future. But in general, maybe sometimes the individual may suffer for this period of depression, followed by a period of mania, and then a period of hypomania, and sometimes they will have depression and mania at the same time, or in the morning the patient is depressed, and in the evening he will be like maniac. So it depends on the patient and the type and many factors. Now, the drug of choice in treating bipolar is lithium. And the other name for these drugs are mood stabilizers. I will not go deep into lithium because I want you to know the details of lithium from the reference that I'll provide you on a separate email or in the e-learning. But I want you to know the lithium, the proposed mechanism of actions, its side effects, and its other uses, if there's any other uses. So you need to know this from the reference and other things. Now, we also have the drug of choice is lithium, but also we have other medications that can be used as maintenance. So once the patient is stable and in the acute phase now, the patient passed it and no problem, either severe depression or mania, so we can use other medications for maintenance. These medications may include anticonvulsants that we will study in the lecture about anti-epileptic medications such as carbamazepine, valproic acid, and lamotrigine, or antipsychotic medications that include the second generation or atypical antipsychotics such as olanzapine and risperidone. This is the end of this lecture. Thank you so much. Please let me know if you have any questions regarding this lecture. Please remember that I will post a reference for you to study the bipolar, lithium specifically, as well as please, this lecture by any means is not a replacement for the material in the book. For the purpose of the exam, this lecture as well as the book will be included in the material in the exam. Thank you again, and I will leave you with some suggested questions.